Video, we are going to talk about weaning patients from mechanical ventilator. The objectives of this video are viewers will be able to understand the weaning criteria, performs the weaning process effectively in the clinical setup, provide appropriate nursing care of your patient on weaning, assist in extubation procedure, and performs post-extubation care. Introduce the topic. Weaning is gradual reduction of ventilation. A new systematic review suggests that non-invasive ventilation after yearly extubation helps in reducing the total days spent on invasive mechanical ventilation. Also, the patients spending less time on invasive ventilation had lower rates of ventilator-associated pneumonia. Liberation or taking out the patient from the mechanical ventilator include three major things, which includes readiness testing, weaning, and extubation. Liberation from mechanical ventilation is an important process in recovery of critically ill patients in the intensive care unit. It is a three-step process consisting of readiness testing, weaning, and extubation. Just to look into the definition of these terms, readiness testing means using objective clinical criteria to determine whether a patient is ready to begin weaning from mechanical ventilation. Whereas the word weaning is the process of decreasing the degree of ventilator support and allowing the patient to assume a greater proportion of their own ventilation. The last term is extubation, which means removal of the endotracheal tube and is the final step in liberation from mechanical ventilation support. Usually, this extubation is performed when the patient is successful at weaning and both airway patency and airway protection measures are in place. So, we'll be discussing each of these in detail. First, we'll look into the weaning. The term weaning is used to describe the gradual process of decreasing ventilator support. Weaning is the gradual withdrawal of a patient from assisted breathing on a life support system or other form of therapy. Usually, weaning is done once a patient is stable and in a position to move towards spontaneous breathing. It is important that the steps are taken to wean the patient of dependency of supported breathing. Weaning a patient from ventilator occurs when the condition of the patient improves and a decision to make to remove them from the ventilator through a trial of spontaneous breathing through the endotracheal tube and eventually extubation, which means removal of the endotracheal tube. Next, we'll see the factors which are associated with the successful weaning. To enable the weaning to be successful, thought has to be given to the following major areas. Usually, we have to look into the underlying condition, improved or not. This is the condition for which the patient is hospitalized and put on the ventilation. If the patient is recovered from that illness, then it indicates the patient can be weaned from the ventilation. The next factor is the patient's dental condition optimal? We'll be discussing about these dental conditions in the weaning criteria in detail. The third factor is, have potential airway problems been identified and remedied? And the fourth one is breathing adequate? That is, the spontaneous breathing taken by the patient is adequate or not. Next, we'll see certain essential factors begin the weaning process. So here there are two different types of factors, that is the patient factors and the ventilator path. First, we'll discuss about the patient parameters. Here, the patient need to be alert, awake, and cooperative and obeying the commands. The second one is the patient should be hemodynamically stable. All the pressures should be within the normal limit. And respiratory rate of the patient should be less than 30 per minute. No effect of sedation or neuromuscular blockade. And there should be a minimal secretions from the respiratory tract. And the patient should maintain the good nutritional status. There are certain general precaution conditions of the patients are, patient should be ready to reverse the primary problem causing the need for mechanical ventilation. As I said, the disease or the illness for which the patient is put on for the mechanical ventilation to be recovered. Patient is awake and responsive, adequate physical strength and mental alertness is necessary. The patient should maintain the ability to cough. Adequate airway patency should be maintained, and patient should be able to swallow, move the jaw, clench the teeth, voluntary cough. Reflex should be effective to bring out the secretion. No or minimal inotropic support is being given to the patient. Ideally, patient must have the functioning bowels and absence of the bowel abdominal distension. Nutritional and fluid balance should be maintained, and normalized metabolic status should be available with the patient, and patient should have the adequate HB concentration. And careful preparation before potential weaning can make the difference in the numerous borderline weanable cases encountered in the intensive care. This is very important because patients who are intubated in general have worst conditions. The other parameters should be reviewed for correctors, or it should be treated as indicated. Major electrolyte should be within normal range. Hematocrit or PCV more than 25%, and core body temperature should be above 36 degrees Celsius and less than 39 degrees Celsius. And patient should be managed adequately for pain, anxiety, and agitation. And it should be given adequate analgesia or sedation, and the record scores on the flow sheet should be maintained. And there should be a decline in the need for the analgesia or the sedation, and no residual neuromuscular blockade will be given to the patient. These are the patient parameters, indicates the patient is ready to wean from the mechanical ventilator. Next, we'll see the ventilator parameters, indicates that the patient can be weaned from the mechanical ventilator. The first one is the vital capacity, which should be around 10 to 15 ml per kg body weight, and maximum inspiratory pressure, that is MIP, at least minus 20 centimeter water. And tidal volume set for the patient is 7 to 9 ml per kg, and the rapid or shallow breathing index should be below 100 breaths per minute, and minute ventilation 6 liter per minute. Oxygen partial pressure be above a given threshold. If these conditions are satisfying in the ventilator set, then the patient can be weaned from the ventilator. So always before weaning, please check the patient parameters, and the ventilator parameters should be within the normal level or indicator level to wean the patient from the mechanical ventilator. Next, we'll see the methods of weaning. Once the patient is ready to wean from the mechanical ventilator, gradually the patient should be weaned off from the ventilator. That there are 4 different methods. One is the TP's trial. Second, continuous positive airway pressure weaning. Synchronized intermittent mandatory ventilation, that is SIMV weaning, and pressure support ventilation, PSV weaning. And TP trials usually involve periods of supported ventilation being gradually broken up by a spontaneous breathing of increasing duration. There is some evidence that once daily breathing trials may be just as effective. Once the patient can manage 2 hours without the problems, they can be extubated. Then you start with the SIMV, where when the patient is on SIMV mode, usually undertaken by gradually reducing the mandatory rates. That is, the breathing rate should be gradually reduced. Maybe if the patient is on 12, then 1 hour, the patient will be put on to the 10 breathing rate, then 8, 6, like that. Gradually, the breathing rate should be weaned up. On a twice daily basis or more regularly, this can be done. The endpoint of this SIMV patient is a rate of 4 to 5 minutes for varying periods of time depending upon the trial. And patients who meet the prescribed criteria then can be extubated. The last method is the PSV, that is the pressure support ventilation, which involves gradually reducing the pressure to assist spontaneous breathing. And most of the trials shows that pressure support of 2 to 4 centimeter water twice a day or more often, if the patient tolerating, can be reduced. The endpoint in the pressure support ventilation should be around 5 to 8 centimeter water for a duration of 2 to 24 hours. Again, patients who have reduced this state can be successfully extubated. So these conditions should be done. Usually, if the patient is on the pressure support ventilation, we reduce the level of the pressures. If they are on the volume, then we go reduce the rate of the breathing. Then we put the patient on the CPAP, then on the TP's trial. Again, we take the ABG and check the ABG level, then we start extubating the patient. This is the methods of weaning the patient from the mechanical ventilator. Next, we'll see the two parts of weaning. Like usually the patient should be weaned to partial ventilator support, or the patient can be weaned to discontinue the ventilator support. Weaning to partial ventilator support is usually reducing the support given by the ventilators, then discontinuing the patient. And this is the way that usually we go with. But there is a little evidence that the partial modes are more effective than the TPS trials. Of these modes, pressure support mode is the best one to wean the patient. Next, we'll see the weaning procedure. And weaning can be done using the spontaneous breathing trials, pressure support ventilation, or synchronized mandatory intermittent ventilation. So we'll discuss about these things in detail. The spontaneous breathing trials in the weaning criteria, I said, like it is of the TPS trial, which allows the patient to breathe by themselves. Here we evaluate the patient's readiness for weaning from the mechanical ventilation and the extubation. Spontaneous breathing is the major diagnostic test to determine if the patient can be successfully admitted under mechanical ventilation. And the spontaneous breathing may be with a low level, that is less than water, then the automatic tube compensation, ATC, or the TPS trial. And the spontaneous trial may last up to 30 minutes. The next thing is the pressure support. Sorry, in spontaneous breathing trial, there are steps which include using the TPs and the CPAP and allowing the patients breathe spontaneously for up to 30 minutes, where we use the lower level of the pressure support up to 8 centimeters of water, then reassess the patient. If the patient tolerates up to step 4, then the patient can be extubated when the ABG and the vital signs are satisfactory. And next is the pressure support ventilation, which is used in conjunction with the spontaneous breathing trials or SIMV mode. We start with the pressure support ventilation at a lower level of 5 to 15 centimeters of water, then decrease the pressure support level by 3 to 6 centimeter intervals until a level which is close to the 5 centimeters of water. If the patient tolerates this level, then we can consider the extubation if the ABG and the vital signs are satisfactory. Next, we'll see weaning using the SIMV mode. When we use the SIMV mode to wean the patient, usually we reduce the frequency by 1 to 3 breaths per minute. And during that time, monitor the SpO2 and obtain the ABG as required. Reduce the SIMV frequency further until a frequency of 2 to 4 breaths per minute is reached. If the patient tolerates these reductions, then consider the extubation permitted. ABG and the vital signs are satisfactory. And this usually SIMV mode should be avoided as a standalone weaning modality according to certain researchers. But SIMV remains an effective tool in providing partial ventilative support during the continuous mechanical ventilation. Next, there are certain things that we need to assess to determine whether the weaning is successful or not. So there are 3 different terminologies that we will be using. We'll be discussing about the weaning success. Weaning success, it is absence of ventilative support at least for 48 hours following the extubation. Weaning in progress is an intermediate category for patients who are extubated but continue to receive ventilative support by non-invasive ventilation. And weaning failure is failure of spontaneous breathing trial or the need for re-intubation within 48 hours following the extubation. So if these criteria or if these stages are in progress, we should remember the differences between what is weaning success, what is weaning progress, and what is weaning failure. So once we know this, we also have to think about the parameters which indicate successful weaning. So when the patient is on weaning, it should be supplemented with the oxygen therapy and the ABG evaluation and the pulse oximetry and bronchodilator therapy, incentive spirometry and chest physiotherapy should be given. And patient should be given adequate nutrition, hydration and humidification of the oxygenation, and crash cart should be kept ready and intubation ready tray should be readily available at the bedside of the patient, and non-invasive ventilator if required should be kept. Oxygen by mask should be provided and continue monitoring in each step of the weaning process. And this is the care bundles that should be used in the intensive care unit to enhance the successful weaning. So next we'll see role of the nurse before weaning. When the patient is being assessed and the patient is made ready for weaning, the nurses has a greater role to play, which includes ensure that the indications for the implementation of mechanical ventilation have improved. It is weaning readiness, weaning criteria should be assessed and recorded. Ensure that all factors that may interfere with the successful weaning are corrected, like acid-base abnormalities, fluid imbalance, and electrolyte abnormalities, infection, fever, anemia, hyperglycemia, correction of blood sugar level, protein and sleep deprivation. All this should be corrected before starting the weaning. And next, we have to assess the readiness for weaning. Ensure that the weaning criteria, that is the patient criteria as well as the ventilator criteria are met. Explain the process of weaning to the patient if the patient is able to follow, and offer reassurance to the patient. Initiate weaning in the morning when the patient is rested. That morning weaning is the most recommended. Then elevate the head of the bed and place the patient upright, and ensure patient airway and suction if necessary before a weaning trial, and provide for rest period on ventilator for 15 to 20 minutes after suctioning. Ensure patient is comfortable and administer pharmacological agents if required, or bronchodilators or sedatives as ordered or indicated. And help the patient through some of the discomfort and apprehension. Support and reassure, which help the patient through the discomfort and apprehension as remains with the patient after initiation of the weaning process. Evaluate and document the patient response to weaning. These are the patient's nursing care before making the patient to be weaned from the ventilator. Next, we'll see when the patient is being weaned, what is the role of the nurses? That is nursing care of the patient being weaned. Wean only during the daytime. As I said earlier, the best time to wean the patient from the mechanical ventilator is in the morning. Assess the client for the weaning criteria. Remain with the patient during initiation of weaning. Monitor activity level, assess dietary intake and lab test. Assess client and family's level of understanding of weaning. Explain that the patient may feel shortness of breath initially and provide encouragement as needed. And you also have to monitor the vital signs, pulse oximetry, ECG readings, EBIG analysis, and respiratory pattern continuously for the first 20 to 30 minutes once the weaning is initiated, then every 5 minutes until weaning is completed. And also monitor the vital signs, pulse oximetry, all this should be done. Implement the weaning method as prescribed. Please follow the protocol suggested by the treating intensivist. Maintain a patient airway, suction the airway as needed. Terminate the weaning if adverse reactions occur. We will be discussing about the factors which indicates that the weaning is failure. So if you identify the weaning failure factors, then terminate the weaning and put the patient on the complete support. Assess the psychological dependence. Because if the physiologic parameter indicates weaning is feasible or patients still resist, then we have to consider the psychological dependence. Next, we'll see the indications of the weaning failure. Most of the time, we start weaning the patient from the mechanical support. After the period of weaning, the patient may not tolerate the weaning process and they will start fighting with the ventilator. There are certain criteria of the weaning failure includes weaning failure. Early signs of failure include tachypnea, using the accessory muscles and paradoxical abdominal movements, dyspnea, chest pain, chest abdomen asynchrony, and diaphoresis. If these symptoms persist, please put the patient on the mechanical ventilator support. The patient is not able to tolerate the weaning process. Then weaning termination criteria and the spontaneous frequency of more than 35 per minute for 5 minutes. And the SpO2 levels falls less than 90%. Heart rate goes above 140 per minute or 120% of the baseline. And systolic pressure is more than 180 mmHg or less than 90 mmHg. And signs of anxiety are use of accessory muscles, tidal volume less than 5 ml per kg, sustained minute volume less than 200 ml per kg per minute, SpO2 less than 90, PaO2 less than 60, and decrease in pH of 7.35 and increase in PaCO2. And these are the ventilator parameters, or the ABG parameters indicates the patient is not able to tolerate the weaning. So terminate the weaning and put the patient back on the ventilator support. So this ventilator support weaning difficulty is usually caused by certain factors. These factors are told as causes of weaning difficulty, and this is causes of weaning difficulty can be of many reasons. First one is the central drive, that is drive to breathe. The patient's spontaneous breathing is reduced to by excessive usage of the sedatives, direct insult to the respiratory center of the patient, and hyperventilation to abnormally low oxygen levels, and metabolic alkalosis usually exacerbated by hypokalemia and the loss of hypoxic drive, usually seen among the patients with the COPD. And clinically, patients may fail to demonstrate respiratory distress and will in time develop the type 2 respiratory failure if the patient is having the central drive issues. And the next cause is the neuromuscular, that is primary neurological disorders like Guillain-Barré syndrome, myasthenia gravis, other critical illness like polyneuropathy, which can be common among the patient with steroids and neuromuscular blocking agents, and the critical care myopathy or malnutrition, electrolyte abnormalities like hypokalemia, hypophosphatemia, hypomagnesemia, hypocalcemia, and hypothyroidism. These are the neuromuscular reasons for weaning failure. And the next is the increased respiratory load. That is three factors which determine the respiratory load of the patient is increased resistance that may be caused by the bronchospasm or thick or increased secretions. Next is the reduced compliance can be due to the pneumonia, pulmonary edema, intrinsic PEEP, pleural effusion, pneumothorax, and paralytic ileus or abdominal distension. All these factors reduces the compliance. The third factor giving rise to the increased respiratory load is the increased ventilation, maybe due to the hypometabolism, which is common among the patient with the sepsis, overfeeding, metabolic acidosis, shock, and the pulmonary embolism. These are the causes for the increased respiratory load. So these three factors like central drive failure, neuromuscular conditions, and the increased respiratory load, these factors will cause the patient to go into the weaning failure. So if the patient is tolerating the weaning, if all necessary care is being given and everything goes well during the weaning process, then the patient can be extubated. That the third step in the liberation of the patient from the mechanical ventilation. And extubation should never be performed to reduce the work of breathing, as it can actually increase after the extubation. And before extubation, we should consider that the patient's ability to clear the secretions and the risk of symptomatic laryngeal edema following the extubation. These two things should be correct assessed, and that include assessing the patient protective reflexes, airway protective reflexes, and like a cough, if the patient should have the adequate coughing ability. And the laryngeal edema may cause of failed extubation among 5 to 22% of the patients who have been extubated within 36 hours. The patient may need the reintubation due to the laryngeal edema. So these two factors should be assessed before extubation. When the patient is ready for extubation, all necessary arrangements should be made to perform the procedure safely. And the physician who performed the extubation must keep in mind that despite taking all precaution, the patient might fall immediately and be prepared for reintubation. This is the main theme of the extubation that we should remember. The entire team should remember the patient's failure to tolerate the extubation. So once everything is ready, then the patient can be extubated. The extubation procedure usually includes, once the decision to extubate the patient is made, FiO2 of the ventilator should be set 100, and this is the pre-oxygenation for possible reintubation. And all the equipment needed to intubate must be within the grasp, including sedative drugs, laryngoscope, endotracheal tube. When we keep the endotracheal tube for the reintubation, usually we keep the half the size of the current tube, and the suction tube and resuscitation cart, that is the crutch cart, all should be available near the patient. If prior intubation of the patient was difficult, then the method that was finally used should be available. And before extubation, a suction is usually performed within the tube and the oral cavity to prevent the aspiration. And the patient is placed in the upright position, and a short explanation about the procedure will be given. And extubation itself is performed either with a bag valve mask, that is the ambu bag, or without one. With an ambu bag, the cuff is deflated and a small positive pressure is constantly applied with the bag while pulling the tube out. Without a bag, the patient is asked to take a deep breath and hold. In that time, the cuff is deflated and the tube is quickly removed. The purpose of both technique is to set exhalation by the patient as the first movement without the tube to decrease the chance of aspiration. So always use the bag mask ventilation or the patient own breathing and coughing to avoid the aspiration. So when the extubation is successfully performed, quickly monitor the patient ability to tolerate the oxygenation and perform with the post-extubation management, which includes the patient is supported by oxygenation, encourage the patient to cough after being extubated, and ensure that extubation criteria are met. Respiratory therapies are advised shortly after the extubation to support the secretion removal, like oropharyngeal suctioning or the chest physiotherapy. And the patient should be closely monitored for any signs of respiratory distress, which is mandated to allow intervention and reintubation. And the patients at risk of reintubation within 48 hours of extubation should be closely monitored and treated accordingly to avoid the reintubation. And more important thing is the documentation, because many of the studies suggest like 15% of patients are at a high risk of reintubation within 48 hours of the extubation. So this post extubation care is very, very important. And usually the high risk patients include those patients who have the cough reflexes ineffective, and those who need secretion suction at a frequency greater than one suction every 2 hours, or patient who is in positive fluid balance and who were intubated because of pneumonia, and who is not fully conscious, and who is suffering from congestive heart failure or COPD. These are the high risk patients who may go into the intubation. So this patient should be closely monitored and the adequate documentation will become necessary. The next, just to touch the non-invasive ventilation, because most of the patients after the extubation, they may be put on with the non-invasive ventilation. Non-invasive ventilation is effective in reducing the rate of reintubation when used immediately after the extubation with the high risk of laryngeal edema. Thus, the benefit of non-invasive ventilation occurs when it is used as a preventive measure yearly after the extubation. So these are the when liberating the patient, that is liberation of the patient from the mechanical ventilation, and some of the weaning criteria, which includes the patient parameters and the ventilator parameters, and the successful weaning criteria, and some of the criteria which indicates that the patient is not tolerating the weaning, that is the weaning failure, and the reasons for the weaning failure. And we also discussed about the extubation and the extubation care and the nursing care of patient being weaned or on weaning. So just to conclude the content of this video, all patients receiving ventilator support should be assessed on a daily basis for their suitability for weaning. This may involve meeting several preconditions and then on the spontaneous breathing trials. If unsuccessful, weaning should be attempted using either the pressure support or daily spontaneous breathing periods of increasing duration. This is all about weaning the patient from the mechanical ventilation. So these are some of the references made, and thank you.